So today's presentation is actually how to integrate personalized medicine into clinical practice. And for those of you who are practitioners, I'm going to assume that you may not already be doing this. Obviously, some of you have already integrated some things into your practice, but I just wanted this to be, hey, if you really have not taken the leap into any of this foray, this is kind of the process that it took for me. This is who I am again. I did put my email on this one, and if anybody would like the slide set, if you email me personally and tell me that you were at the conference, I'd be happy to share my slide set. Again, just that because we are using real patient data, again, educational purposes only, please don't publish. Again, my motto, if you're not first, you're last. I absolutely love this statement. And this is who I am, and for you, this is the view out of my window at my house.
That's amazing.
Yeah, so I'm in Aspen.
Oh my gosh, I'll have to come and visit you.
We're on Main Street. Come visit us. Okay, so integrating personalized medicine into your clinical practice, one of the things you're going to first look at is, well, what are you currently doing? For a lot of physicians, they are still in an insurance-only based model, and that was my practice for most of my career. However, I did start doing Botox and fillers about 25 years ago. So I did have just this sort of little side practice that was away from my other practice where I was a partner. And so I very, very quickly went into hey, people are willing to pay cash for certain things. And like I said yesterday, if you think that patients won't pay cash, you've just never asked them. They're willing to pay cash for things. You just have to offer them something that they want and not give them an option that they can get it for insurance. If you offer it to them for insurance, they're going to go for that every time. And then your reimbursement is going to be going down. Perhaps you're already in a cash pay model. That is my current model. I do not accept any insurance. The membership that my patients pays for my time. If we do submit any labs to LabCorp, we will send their insurance card to LabCorp, but that's dealing with the lab. It's not dealing with me. I don't count on insurance for anything. My particular model is a membership model where you have to be a member in order to see me. I do offer free consultations because it's an interview. I want to make sure that this is somebody that I want to work with, and they need to see who am I, and am I what they're looking for. And I distinguish this a little bit from the concierge model, partly for legal reasons. I had initially started my practice under the tutelage of another company, and she was concierge medicine, and I had a non-compete, and so I had to take the word concierge out of my practice. That's basically what happened. You certainly can have a mixed model. I have a nurse practitioner in my practice who's been in Aspen for 50 years. She is a nurse midwife. She was the first nurse midwife in the state of Colorado. And because she has 50 years worth of patients, she still sees her patients under the insurance model. So we keep that part of the practice, but I do not actually see any insurance-based patients. The next thing is, what are you trying to accomplish? When I envisioned this practice as a longevity practice, I basically sat down with a legal-sized piece of paper and just said, okay, what tests have you been offering over the course of the last 18 years? What tests do you want to order and offer? And then I started doing some internet research. And again, as I got into this practice of longevity, you're reading on a daily basis. I found out about Theriome through Micah. It's one of his emails. I had bought his ozone machine and got on his email list, and the next thing I know, he's talking about Theriome. So that's how I was introduced to this company. But it also is very much, if you're out there looking, the universe is going to provide for you. It's going to give you things like that. The next thing you really need to consider is, what education do you need? We were talking about this a little bit last night, that this test itself, while you can take their recommendations, the first two patients that I did through Theriome, I did have a conference call with Dr. Jasby After that, I felt pretty comfortable with using the results and making my own recommendations. But in the very, very beginning, it was just kind of like, what does this all mean? Again, for me, I did do a fellowship in anti-aging. I am board certified through A4M with that. Not everybody is going to want to do that kind of education. What kind of therapies are you going to offer? You know, there's a lot of regenerative therapies, IV therapy, and we'll go into each one of these a little bit more. And this is the big one that I made a big change this year, is what kind of business support will you need? As a physician in private practice, I've always been in private practice. I was not taught any business, but I also thought that I could just do it all. And this year I did bring on an executive team. I have an interim CEO and an interim COO who are coming in and helping me run my practice. The day-to-day business model, they are all new hires go through them. We're putting together processes, procedures, protocols. Everything is being digitized so that we can take this. If we ever bring on another nurse or another physician, it's all going to be very, very seamless. And I will not need their support forever, but it wasn't something I had ever considered before. Why would I need a business person? But again, this is a business, and it is a multi-million-dollar business, and no other business would do this on their own. You brought in a CEO, so. Next thing, what kind of financial outcome or expenditure are you going to have? One of the first questions you need to ask is, how much does it cost to run your practice? It's amazing how many physicians don't know. If you ask them, how much does it cost to see a patient? They will say, well, I charge $360 for an annual exam, so it's $360. No, that's not true. You need to know what your rent is, what you're paying your office staff, what is your salary. All of that needs to be included in that. And that's actually just a mathematical equation. When I was choosing how much I would charge for my membership, it came down to, I wanted to replace everything that it cost me. I wanted all of my fixed expenses to be covered by the membership. And that anything else that I did, any testing, any therapies, were then just basically over and above. So it became a mathematical equation. This is how much it costs to run my practice. I want to see 100 patients. What does that number look like? And it turned out to be about $1,000 a month or $11,000 a year per patient. And that's just the base cost. So you're going into it with your expenses completely paid. Next question, and this is an important one, how much money do you want to make? It's in private practice for all of those years, it was you're the last one to be paid in your practice. If you own your practice and you didn't make enough money that month, it's not that you're not paying your employees, it's not that you're not paying your rent, you're not getting paid. And so you do need to make a reasonable salary or a decent living. We're working on this one. This one's going to go higher for me in the very near future. In a practice such as mine, it does come down to how many patients do you want to see? How many patients can you take care of in an exceptionally great fashion? We heard 150 yesterday is the tribe number. I did not know that number, and that's a wonderful one. There was recently, about a year before I went into my membership practice, one of the internal medicine doctors in the Valley went concierge, and he's charging $2,000 a year. He has 500 patients. I knew that I could not take care of 500 patients and give them the kind of care that they were getting. I think he's undercharging, and I think he has way too many patients to see, and now he does admit that that is the case. He also went with a practice called MD VIP, and their hook is that they will sell your patients on the idea of being in a concierge practice. They take 50% of your concierge fee for every patient, so he's basically only making $1,000 a patient. 500 patients, that's $500,000. I don't know if that covers his practice expenses. He's in Basalt, which is a smaller town near us, so his expenses probably are a little bit less than mine. But I certainly wasn't going to give 50% of my revenue to a company just for them to convince my patients that they needed to come see me. What are your staffing needs? We run a very mean and small practice. I have two front office girls. One of them is actually my daughter. I currently have a nurse part-time. I have a nurse practitioner who's part-time. My husband does work with me as well. It's very much a family business, and he does billing and problem solving. Basically, any patients that my front office girls don't want to talk to, or if they're trying to be mean to him, he gets on the phone and settles them right out. It's amazing how a male voice, just the women just don't feel like that they can yell at him, and they feel comfortable yelling at girls. And the sort of the last money thing is, what kind of revenue streams are you going to have? So for me, I do have my membership fees coming in. We do a lot of therapies. We do sell vitamins. And so we do have multiple revenue streams coming in. This is a list of the advanced testing that I offer. I do not do all of them every time. True Diagnostic is on this, and I have very recently decided that it does not give me any information that's actionable, that I can get that in other places, so I would rather spend my patients' money on tests that are going to give me the most bang for the buck and really make a difference in their lives. I do toxicity testing on every single patient. Theriome is right up there, this multifunction cardiogram, and we'll go into that in a little bit. And I do like whole genome genetics. The way I explain it to my patients is, when we know your genome, information is power. We can know if you do have ApoE4 and you're homozygous for this. This does not mean you're going to get Alzheimer's, but let's do everything in our humanly possible to try to prevent that for you. Gallery Grail is an early cancer detection test. It's a blood test, and they're looking for acellular DNA in your blood. They can look for 50 different kinds of cancers in stage 1. They're particularly good at looking for cancers that we don't currently have screening tests for: pancreatic cancer, lung cancer, brain cancer, things like that. They can look for ovarian cancer, but they're really good at the ones where we can't figure it out. And they did do some predictions. When it comes to colon cancer, they can pick up colon cancer in their test about 3 years before it's clinically evident. With pancreatic cancer, it's a little bit smaller. Pancreatic cancer seems to be a little faster growing. They're right at the 6-7 month mark. I do recommend this test for everyone over the age of 50 every year. The number one risk factor for developing cancer is being over the age of 50, not genetic factors. Almost all of my patients think it's genetic, and it's not. It's age alone. Telomere length, I use Life Length. They are dedicated. I've used them for about 18 years now. It's reproducible because you're able to get an average telomere length and then your shortest telomeres. It's sensitive enough that you can do a repeat test and tell if you're actually getting anywhere. If you're just doing average length, you're not going to be sensitive enough to really say, hey, I did move the needle on this biomarker. Senescence panel, this is a fairly new panel. It is looking at IL-6, IL-8, a lot of different ones. Basically, they're senescent markers, and senescent cells or zombie cells are those cells that are no longer functioning members of the community. Let's say it's a liver cell, it's no longer doing liver things, it can no longer divide, but it's not sitting there doing nothing. It's spewing out inflammatory cytokines, it's invading the cells next to it, recruiting them into that inflammatory cascade, so it's an inflammaging process. And if we can measure, do you have a lot of senescent cells, then I can target my therapy at trying to get rid of those. Again, True Diagnostic, they are a DNA methylation test, and they do tout themselves as being an omic marker. They do give you several different biological age clocks, none of which, like I said, after I did about 30 tests, I decided, yeah, I'm just telling patients information, but they said, well, what are we going to do about this? And I'm like, basically, I don't know. NutriEval is something that I've used in the past. This is a blood and oftentimes a first morning void, especially to get your amino acids. I no longer need this test now that I have Theriome. NAD, the company is called Ginfinity. He does do an intracellular NAD level, and I have found this helpful when I am trying to see, is my therapy working? Again, prior to Theriome. Now I have another test that can tell me. I'm looking for things that are measurable. I can then do a therapy and I can remeasure and make sure that we're achieving our goals. The organic acid test comes from, used to be Great Plains, now they're Mosaic, and I am no longer adding the organic acid test since I have switched to Therium. Some of the other tests that I don't, may not personally do in my office, the Prenuvo company does a whole body MRI. It's amazing how many of my patients have chosen to do this. Again, my patient population, for many of them, money is not an issue. It's around $2,500 to do a whole body MRI. We've had several findings. We've not found any cancers, but I did have a lady who was about 52, and it had shown that her brain had shrunk more than expected based on age alone. And instead of just saying, wow, isn't that interesting, we're like, well, let's figure out what that is. She ended up getting, going to the Amen clinics and getting a SPECT scan. And it turned out that her problem was she's in a very, very, very stressful lawsuit right now, and she can't let it go. She cannot, she's so angry about the whole process that she's taking that with her all day long and to bed, and it's ruining her health. It's shrinking her brain. So we're working with her to try to do some stress management, some trauma management as well with that. A pelvic ultrasound, I do offer this for all of my women as they come in. I still do annual exams for my ladies. I will do an annual exam on a man except for a prostate exam. And I explain to them, look, I was a gynecologist. I have not done a rectal exam on a man in 30 years. I just don't feel comfortable me starting now. If you need that, we're going to send you to the urologist. But on my female patients, I do a GYN exam. And I will pull in my portable ultrasound machine, and we'll just do a pelvic ultrasound right at the same time. I can rule out ovarian cancer in approximately 3 minutes. And I don't have to ask insurance anymore. Prior to when I was still doing insurance-based, if you did an annual exam, you're not allowed to do a problem visit code at the same time, or insurance is not going to pay you for either one. So you would have to bring them back for another visit. Now I don't have to answer to insurance for anything, and this is just good medicine. I want to know. So we do that on everyone. I do use Cologuard a lot instead of colonoscopy. Obviously, there's exceptions. If you have a patient who has a family history or prior history of polyps, they're going to go straight to colonoscopy, but Cologuard we do use a lot. I still order mammograms. I will order thermograms. Interestingly, for women who have the BRCA gene mutation, what that mutation is a DNA repair mechanism problem. So if you are giving them mammograms, which is ionizing radiation, and that's causing DNA damage that they cannot repair, and what we recommend for those women is to have more mammograms. To me, it seems counterintuitive. I would much rather do MRIs, although the standard of care is still mammograms. But a lot of times for women, I'll say, why don't we get you started on thermograms? At least we can have some baseline and some images moving forward so that maybe we can space out the mammograms. And I realize I'm going against convention and standard of care, but I inform my patients of that, so I feel comfortable with it. A DEXA and a body composition, especially as we're dealing with patients, if we're putting them on any of the GLP-1 agonist, when they're doing weight loss with that, there is a tremendous amount or potential for muscle mass loss. And so we want to make sure that we're looking at that and doing some kind of program to help prevent that. Carotid artery ultrasounds, looking for plaque and or stenosis. A coronary calcium score, which simply gives me, this is how much calcium or plaque that you have built up. I do like the CT angiogram better, and then we send that disc to the company clearly. Clearly we'll look at it and digitize it and tell us, okay, this is how much stable plaque you have, this is how much soft plaque you have, this is what's at risk for rupture. So we get a much clearer picture of, are they in imminent danger of having some kind of an event. Gut biome, I am doing this for some of my patients, not very many. I'm really waiting. Alex, when you get your test ready, we will be introducing that. I do still do pap smears. Oh, what a disservice the country has done by telling women that they only need pap smears every 3 to 5 years. A major pet peeve of mine. You know, as a gynecologist, I saw women. I had an 18-year-old who had one step away from cancer, and now they're telling you you shouldn't even begin Pap smears until you're 21. That 18-year-old would have died had we not intervened at that point. I do recommend HPV and Pap testing every single year. And then the brain SPECT scan we get usually through the Amen clinics. Does everybody know who Dr. Amen is? Dr. Amen, he's a psychiatrist who in the 1990s had this revolutionary idea that psychiatrists are the only physicians who do not image the body part that they treat, that everything is done just based on symptoms alone. And he said, what if we image the brain in a dynamic way? So the SPECT scan is imaging the blood flow to the brain. He has been ridiculed for almost 30 years. The medical community is just now starting to come back and support him. Even people who told him he should be jailed because of what he was doing are really now starting to come on board. I actually had my test in Dallas when I was in Dallas last month. And
The bald guy. Sorry.
Yeah. He's on PBS. That's where I first heard of him. Is, you know, he does a lot of, you know, save your brain things on PBS. But everybody, again, has test envy, brain envy. I did have a couple of areas of concern and that we're working on, so I was really happy that I did it. Lab testing through LabCorp, Quest, or any other test. I also use a company called Access Labs. They're out of Florida. They're a cash-only lab. And for patients where, you know, if I'm ordering $3,000 worth of lab work and they have not yet met their deductible and money is a concern, I will go through Access because I can get them this same panel for about $800. The reason I'm still doing regular blood work, I will tell you, the vast majority of the time I'm looking at hemoglobin A1C. I am looking at their thyroid antibodies. I want to know if they have Hashimoto's or Graves' disease, and ANA, if they have any kind of joint pain. We're looking for rheumatoid factor. We're looking for any kind of inflammatory conditions. And again, I want a very big snapshot of where you are right now so that I can figure out what your problem list is and what are we going to address. So this is not an exhaustive list, but this would be a typical panel that I would run through LabCorp. All of this leads up to, what are we trying to figure out? We're trying to figure out what is going on with this patient right now. Now, I do ask them, you know, what are your medical concerns? What are your current health concerns? What are your health goals? But then I'm going to take the data to help me tease out exactly what is going on. And again, I want something measurable so that I can go back and look and see what progress we're getting. A lot of times patients are going to feel a lot better, but it's also very easy when you can point to a test and show, look how much better you got on paper as well. And I did that with myself. You know, I've been working on my health for 2.5 years now, and I was able to look at markers all along the way and have some pretty impressive results from that. So therapies that you might consider in an advanced practice like this, hormones. You know, I have been doing hormones. As a gynecologist, I was still in the era when they taught us hormones in residency. They are now basically not teaching OBGYNs hormones since 2002, which is just a travesty. You can go get trained in hormones. I would tell you I do have a pet peeve. I don't think that you can go to a weekend course and become an expert in hormones, especially bioidentical hormones. It takes a lot. There are certainly some steps in the beginning that you might take, broad strokes, say, you know, a woman is going to probably need progesterone. She's probably progesterone deficient early in perimenopause, but to really get it right, it takes years of practice. I do offer IV therapy in my practice. We've been doing IVs for about 15 years. This phosphatidylcholine IV that I talked about yesterday, it is used, like I said, in Europe as a detoxification IV. It's incredible for the brain. The phosphatidylcholine does go to the brain, and you will get very great results. I'll give you an example. I had a patient who did have MTHFR deficiency, and one fall she developed bronchitis, and over the course of 12 weeks they put her on 12 different antibiotics none of them worked, but the problem was that they overdosed her with those antibiotics and her body couldn't handle it. And she went into an acute chronic fatigue. She could not hardly get out of bed. But she said her mom had taught speed reading when she was a little girl, and that she's been able to speed read since she was a 3-year-old. And she came to me and said, I cannot read a sentence. It doesn't make sense to me. My brain does not work. We decided, because she had such severe deficits, that we were going to do the PCIVs. It's a course of 10 IVs that we recommend. That's based out of the literature out of Bavaria. And because she had such bad deficits, we said we're going to do these 1 a week until we get this in you. By the time she came for her second IV, just having one, she said her brain was back. We were able to bring her brain back with just 1 IV. By about the 6th IV, she was able to carry her 8-year-old niece around on a piggyback ride. So we were able to bring her back completely from her overdose. Hyperbaric oxygen, I don't offer this personally in my practice, but it is something that I will prescribe for patients. Hyperbaric oxygen really is showing promise in stem cell, regenerating your own stem cells and other regenerative conditions. Regenerative therapies, I personally have had umbilical cord stem cells. I did go to Costa Rica to get that. Right after that, we found an exosome product that I can legally inject in the United States. Most exosome products came to the market as cosmetic. And if they are FDA approved for a cosmetic use and you give that to somebody in an IV and they have a problem, you can hand over your medical license. That is just not okay. But there is now an exosome product that legally I can inject. But as of January of this year, we've switched to something called cell factors. And the difference is the exosomes that we were using before were only umbilical cord stem cell derived. So the exosomes are the extracellular vesicles that the stem cells release. That has all of the healing factors in it. The cell factors are whole placental derived. So they are stem cells, but they're getting it from the entire placenta, the amnion, the chorion, the amniotic fluid, the cord blood. So you're getting the entire progeny to your entire body, so I can regenerate nerves, blood vessels, not just mesenchymal, which is muscle and connective tissue. So as of January, we have switched most everything that we are injecting now as cell factors. Are you going to offer cosmetic treatments in your practice? Again, that's what I started with 25 years ago, Botox and filler. And I always find it quite funny when the dermatologists complain that, how dare you as a gynecologist inject things? And I'm like, I've been injecting these before you went to medical school. I don't want to hear how I'm not qualified to do this. I have approximately $2 million worth of lasers. I have a problem. I'm Dr. King and I have a problem. I buy lasers. My CEO has forbid me from buying any more products, and I would tell you it's been helpful to have somebody kind of put her thumb down on me and say, hey, look, we got to get out from under some of this debt that you have, and at that point, obviously, my income will go up. But we do microneedling. I was doing liposuction in my office. I was doing some actually surgical procedures. As a surgeon, I was able to do that under my malpractice. They did cover me to do those things. We've really pared that down to the things that are less invasive. I work with a company, BTL, M-Sculpt Neo, which is the muscle stimulating machine. Absolutely love it. Their products are really top notch and non-invasive, and you can hand that off to an esthetician or even a nurse to do. I do sell supplements. I'm very picky about it. I want to make sure that they're prescription grade. I want to make sure that they are quality. When I did discover Quicksilver Scientific, just basically the beginning of this year, once I saw their science and their data as far as how absorbable and bioavailable their products are, I have incorporated that. We do have a wholesale account with them, and so yes, I do make money on supplements. It's enough to make it worthwhile. It certainly is not a game changer for my practice. You may be prescribing prescription medications. I certainly do. We do some nutrition. I was never trained in nutrition. I don't know about any of you if you got any nutrition in your medical school, but I don't remember actually having a minute of that. That's something that I've kind of learned over time. We do have nutritionists in the valley that I can refer somebody to if it's outside the area of what I feel comfortable doing right now. Am I going to prescribe an exercise protocol? Am I going to prescribe them exercise? And a lot of them are using personal trainers. And I'm going to leave that to the personal trainers. I'm certainly not going to go to the gym with them and, have them do their weightlifting. And weight loss has become a pretty big business. It's already in Aspen. It's becoming fairly cutthroat. I just don't deal with anybody who's outside my concierge practice. I will provide that service for them, but I'm not just letting anybody in. And then the ... to be continued, where we don't know where the future goes. So if you're coming into my practice as a new concierge or a member, this is the bare minimum that I am going to recommend that you do. Again, a lot of my patients will take that entire list of tests that I offer and may choose to do absolutely everything on that list. Those patients who are cost conscious, if they cannot afford to do these 4 tests, I look at them and really say, I don't know what I'm going to be able to do for you. You want me to figure out what's going on with you, but if I can't do at least these, then you're really tying my hands behind my back, and maybe you just need to find somebody else that you can work with, that you can afford to work with. So toxicity testing is a must. Every patient I've ever tested is toxic. Every patient has glyphosate Roundup. I have 3 women who live on organic farms. They all have glyphosate. So eating organic, living organic does not guarantee that you're not getting it. It's just so pervasive in the environment. The therium test has now become an absolute must. Again, if we're going to do this, let's get the most information we can. The MCG, which is this multifunction cardiogram, and then that LabCorp testing. Again, I really want to know, do you have Hashimoto's? I had a gentleman who had been seeing another doctor, and he wanted weight loss. And he had been working with this doctor for approximately 1.5 years. He did have him on testosterone therapy, and he was on Mounjaro, which is Lilly's product, a GLP-1 agonist with the second receptor. Had not lost any weight whatsoever. He sent me his lab work, and I said, okay, what is he doing about your prediabetes, your kidney disease, your vitamin D deficiency, and your Hashimoto's? And he wrote back, kidney disease, prediabetes, and I'm like, I'm just reading the labs that you sent me from your other doctor. And the other doctor had ordered these tests, but had completely and utterly ignored them. Once we got him, and he was hypothyroid. It wasn't just Hashimoto's, he was hypothyroid as well. So once we got him on his thyroid medication, his low-dose naltrexone, his vitamin D, and got everything optimized, he started losing weight immediately. I think he's down about 30 pounds now, and I've only been working with him about 4 months. How to start? I always say, why not start with the low-hanging fruit? If you're not going to jump into this full force like I did, I literally left a surgical practice that was incredibly full and jumped into hey, you can only see me if you're going to pay me. But if you want to go into this, just dip your toes in the water, why not do something where you're not going to have any risk involved with it? If you're doing testing that has little or no investment on your part, you're going to sell that test for at least what you're paying for it, and if you are getting a discount, you're going to sell it for at least retail. You want to make sure that whatever test you're doing is giving you actionable information. Again, why are you doing it? If you're going to do a test and then ignore the results, why did that other doctor even do that testing if he wasn't even going to look at it or manage any of that person's problems? And it should also give you some kind of therapy guidance. For me, I think the 3 that fit that bill would be the Therium Aristotle test, toxicity testing, and actually genetic testing. We've seen this. This is an example of the digital twinning result. This is just the first graph that we get. In this particular person, they basically are normal and everything. Again, I'm looking, is there anything red that I need to be critically concerned about and addressing first? their digital twinning protocol. How I explain this to my patients when they come in is there's a brand new test. It's a blood test. We can either draw it from you or most likely just do a finger stick. They take your blood, they look for 126 different metabolites. They take your data and put it into the AI computer, and then in that they create your digital twin, and then they subject your digital twin to 1,000 different permutations of diet, exercise, and supplement change so that I don't have to do that for you. But what I get back is this incredibly detailed report, exactly what we need to do for you to make a change for you. 30-second speech, not a single patient of mine has refused, or they all are basically, can I bring my husband in now to get it done as well? This test, multifunction cardiogram, the company is HeartCare Corp. They've been around since approximately 2011, and unfortunately, they really need someone who is better at marketing. I believe this machine should be in every primary care doctor's office in the country. So it is an advanced EKG. It is able to look for microvascular heart disease in women. It is predictive up to 10 years in advance of an event happening. And I'll show you some of the diagrams for this. It is fairly pricey to purchase. I did purchase my machine. They are a pay-per-click. So in addition to buying the machine for every test that you do, it cost $100. I was able to buy a package of $250 up front. And so far, we've probably done 150 tests on this. So it's definitely paid for itself within the first year of having it. They do offer an option where if you do not wish to buy the machine, but you want to offer it, if you say we're going to have a testing day and you arrange maybe 15 patients in your office, they will fly in with the machine with a technician who will do all the testing for you. You charge for the testing. It costs pay-per-click more for that, but that is an option. You don't have to have a major capital expenditure if you don't want to. So this is the first page of the test report, and this is one of my patients. So what we're able to see on here is that we're doing a total of 5 separate tests. Each test lasts 82 seconds long. So when we're doing this test, they're laying very quietly. They have clamps on their wrists and their ankles, and then one EKG pad on the left side. They need to lie very still. I am watching the EKG monitor go by the entire time, so I know if they're having any arrhythmias or anything like that. When you get a total of 5 tests that are of either marginal or good quality, you can then send it into the AI computer. If it's a poor quality, you're not going to send it in to be looked at. So sometimes you have to do more than 5 tests in order to get enough that are that you can actually send in. And then it's looking at ischemia. Sorry if I'm in your way there. In this particular gentleman, he has local ischemia present on all 5 tests. So local ischemia means there's an area of the heart that's perceiving it's not getting enough oxygen, and it's probably in either one vessel or it's not globally, it's not all over the heart. He happens to have no global ischemia, but his severity scores range from 4.5 to 7. This is on a scale of 0 to 22. Just to give you an example, this gentleman has known atherosclerosis, and we'll see that in the next slide. He actually is not getting worse. I did his test last year. This is his most recent test. But if he was getting worse and he was in that 8-9 area, I am going to be sending him to a cardiologist because he may need some intervention at that point. This is the top of the second page that you get, and these are all of the parameters that this test is going to be able to tell you. The doctor who created this test decided to name everything with traditional cardiology terms, but that's not exactly what they mean. First thing I look for is something called myocardial damage. That actually means that there is an inflammatory metabolic condition going on, and there's a slide that's going to talk about that here in just a minute. In this particular case, he has 5 out of 5 of his tests showing positive for that inflammatory metabolic condition. So we're going to be looking at what those are and try to address each of them individually. Myocarditis is actually acute inflammation. Interestingly, he doesn't have acute inflammation. Again, he's been working with me for a year now on some of his heart health and other things, and so those markers are gone. We can tell which side of the heart the problem is. He had local ischemia, so we're trying to figure out is it right or left side of the heart. Rheumatic heart disease is left side, pulmonary heart disease is right side. He has 5 markers for right side, only 3 for left, so we would say he has right-sided vessel disease. Congenital heart disease is exactly what it says it is, as well as ventricular hypertrophy. Cardiomyopathy actually means heart wall stiffening. He does have some markers for that. And then when we get into the arrhythmias, ventricular arrhythmia, he was having a few PVCs actually. As I was doing his tests, I was able to see that. But this model is predicting, again, it can predict up to 10 years in the future. So it's looking at if we don't do something to your heart now and change this trajectory, you're going to go into ventricular fibrillation and you're going to die. So pretty important stuff to know about him. This is the bottom half of that second page. And on here, this is where, when I was talking yesterday about having methylation issues, the 2 areas that show that is acute power failure and a decreased ejection fraction. Actually, these are mitochondrial markers. So this is showing that he has significant mitochondrial dysfunction. But he's got 5 out of 5 markers for acute power failure, 4 out of 5 for decreased ejection fraction. Now, I knew that he had the MTHFR deficiency. He just wasn't taking his methylfolate. So when I showed him his test last year and I showed him this one, and I'm like, look, we knew this about you. We've known it about you. Why are you not taking your methylfolate? I think he finally did get the picture that he really does need it. It kind of hammered it home for him. And if you do get somebody sufficiently repleted with methylfolate or other methylation groups, those markers will go away. And I have had several people where the first test was maybe their severity score was a 3 with a lot of methylation markers. And the next year, because they were compliant, those markers are gone. And I have one lady, her scores all went to 0. So we were able to clear all of her microvascular disease.
Can I ask you, when you supplement with methylfolate, say, do you also supplement with methylcobalamin? How do you approach
The
that?
product that I use has 15 milligrams of methylfolate and 1,000 micrograms of methyl B12. So that's my preferred product. So it does have both.
And any SAMI in it?
It does not, but there are some of my other products that do, or trimethylglycine. So it kind of depends, especially if I know genetically that they have, the COMT gene, I may preferentially use that as opposed to if we're just dealing with MTHFR.
Okay,
yeah.
thank you.
And interestingly, I learned this from Dr. Sam, who taught me how to read these, that in the United States, we've always told people that if you have this defect that you need 1 milligram of methylfolate. The European literature actually shows that if you have the 677 gene, it's 15 milligrams. If you have the 1298 gene, you need 45 milligrams of L-methylfolate for 3 months, and then you're on 15 milligrams for life. And you do have to remind them, look, you were born this way. We're not doing gene editing yet. You're going to have to take this for life. This gentleman we know actually has plaque, and that's showing up here in this increased myocardial compliance. Increased means he has more than 30% plaque burden, and we're also over here in global asynchrony. And here the arrow points to the side of the heart. So lead V5 is left. It's pointing to the other side, so right. So that goes along with what we found on the top part of the report where it was showing right-sided heart disease. And we do know that he has plaque burden. So this will tell us whether they have plaque, yes or no. So I love this test. Again, I'm doing it on my patients, even young patients. I'm in their 30s. We're finding things. So this is just a little refresher. Folic acid is what we eat in our food. Our body doesn't use it that way. We need to convert it to methylfolate through the MTHFR gene. There is a 40% mutation rate for this gene. And the most common 2 genes are 677 and 1298. There are a few other minor ones, but these are going to cause most of the problem. So these are the 10 inflammatory metabolic conditions that can cause heart disease. And I have this in my office. It's laminated. I bring it out as we're going through their test, and we're going to go through each one of these. We've done regular blood work. I'm going to be able to tell, are you diabetic or pre-diabetic? I'm going to be able to tell about chronic kidney disease. I've taken your blood pressure. I know what your cholesterol is. Obviously, you can tell if they have extra weight. Sleep disturbances, you're going to have to ask them about. Do you have sleep apnea? Do you have insomnia? Are you waking up at night? Mental health disorders, I actually wish I could change this. These are the methylation issues. And obviously, you all probably know that in order to break down your neurotransmitters, that requires methylation. So there's a high incidence of OCD, panic disorders, depression for people who don't methylate well. Other genetic disorders, this might be cardiomyopathy or other genetic cholesterol issues. Autoimmune falls in here, so Hashimoto's, I'm going to be looking for that all the time. And then the gut microbiome is a huge part of this as well. And the idea, like I said, is we literally make a list. Okay, you're pre-diabetic, you have hypertension, you've already got some kidney disease, you're Hashimoto's, and we're going to try to address each one that we can because these are causing the heart disease. And if I can address each one at its root cause, then we're going to make we can actually reverse heart disease.
That's a question. You mentioned Access Lab. Do you use LabCorp very much?
I do use LabCorp predominantly.
LabCorp for TPO for Hashimoto's is 0 to 34. Access is 0 to 60.
What should their TPO be?
What, in your opinion, what do you think it should be?
0. You should have no autoimmune antibodies in you should have 0. I don't care what the lab.
Nobody tests for that?
Well, I test for it, yeah.
I mean, majority.
No, but I also have a lot of patients who have both TPO and antithyroglobulin antibodies. That's for Graves. And I've had internal medicine doctors in Aspen tell me it's impossible. They can't have Graves and Hashimoto's at the same time. I'm like, they're just 2 autoimmune diseases. Of course you can have that. They're like, well, they can't be hyper and hypo at the same time. And I'm like, yes, I agree with that. But that has nothing to do with the autoimmune disease. So, but you should have, your autoimmune antibodies should be 0. You should not be attacking your body at all. So I don't care what the lab says is normal. To me, it doesn't matter. It should be 0. And if they're 17 on either test, they're still Hashimoto's.
I'm just curious, LabCorp over Rupa Health, why did you go with the LabCorp?
I've been using LabCorp in my practice for 20 years. They pick up at my office literally every day. We just have an automatic service with that. Rupa, I do have an account with them. I've never used them. As my practice, a lot of my patients don't live in Aspen, and so if I do need to get a lab, they will do some home visits. They can provide home phlebotomy services, so that's why I might use them. But if they're coming to my office and LabCorp's picking up on a daily basis, I'm just going to use LabCorp. It comes down to convenience. Toxicities. All right. Currently, through Mosaic, I cannot get solvents and persistent organic pollutants. Their machines have been down for almost 9 months now. I'm going to try to find another way to get those. But right now I can currently test for glyphosate, which is Roundup. And again, every person I've tested has Roundup. Mold toxicities, had a gentleman whose mold came back that he had Stachybotrys, and I said, you are going to go get your home and office tested. Turned out it was his home. He had black mold in his home, and he had to do a complete remediation. But he started feeling better, no headaches. A lot of things that he just thought was parts of aging went away immediately once we remediated that for him. Plus, we've had to detox his body from it. And then heavy metals. When I'm doing my heavy metals testing, it is just a random test. We're not doing a provoked test. So I always tell my patients, look, this is probably underrepresenting what your true body burden is. So if anything's showing up, we're going to try to get rid of it. This is this gentleman where you can see he's basically in the 99th percentile for glyphosate toxicity. He does not eat organic, but obviously he has issues with getting rid of it as well. His toxic metal test only showed anything in the yellow I'm going to be treating, but also mercury, lead, they're above. I want them very, very far over to the left in the green. So all of this we're going to try to get rid of for him. There are some radioactive compounds on here, and for that it's mostly antioxidant therapy that we're going to do for that. Otherwise, the phosphatidylcholine IVs work really, really well at detoxing people from heavy metals. So this is his ochratoxin. Again, that's aspergillus. Aspergillus is in the environment, it's in the water, it's just pervasive. But when I see very high levels like this, I start thinking they probably do have aspergillus growing in their gut as well. Just a slide to just show you, really patients underestimate how significant mold toxicities are. His ochratoxin A is in every single category here. It can cause neurotoxicity, it can cause kidney damage, it can cause cancers, and so we need to get this out of his body. So what good is testing if you're not going to do any kind of therapy for it? So what we have for that is, obviously, the low-hanging fruit here is remove the exposure. If they're, if you have a moldy house, get your house, either move out or get it remediated. If you're not eating organic, try to eat organic as much as you can. It's about getting them to a threshold. If you can get them down below a threshold where it's not causing damage to them, then we can deal with that ongoing daily exposure, because detoxifying them once isn't going to really, it's going to help immediately, but you're talking about a lifetime, and unfortunately it's not changing very soon in the United States for that. These PCIVs I do, like I said, that's my primary detoxification therapy. We now do the oral detox program through Quicksilver, and their products are actually really quite nice at bringing this out. They will get the molds, they will get the heavy metals. With using their ultra binder and binding those toxins in the gut, you're eliminating the enterohepatic recirculation there. Sauna, obviously hydration, electrolytes, they need to make sure that they're moving things through their kidneys. Are they constipated? Oh my goodness. I tell people, look, there's a reason you poo every day. You need to get rid of that. That is waste, and it needs to get out of your body. And then again, if they do have dysbiosis, especially fungal infections or growth in their intestine, we need to address that. Gallery Grail, the early cancer test. I get this test back in about a week. Now, this company does not offer a very big discount. Their list price is $949. I think they give it to me for $879, barely enough to cover my 3% credit card processing. I actually ended up starting to mark this up just slightly, $1,049, just so that we can make it worth our while. But if you get a negative result, it's going to come back like this. If it comes back positive, they are going to say, and we think you need to look here. It's not just a free-for-all, hey, there's cancer somewhere, go figure it out. They'll say, and go look in the pancreas. This is the Ginfinity intracellular NAD test. In this particular person, they're falling in the orange category, which is deficient. This company does sell an NAD product, and so their deal is you test for intracellular NAD, you take whatever therapy, then you can retest and make sure that you're actually absorbing it and it's getting you the result you need. They do offer this Aging SOS. This is the senescence panel that I was talking about. This particular person did have the interleukin 8, and their intracellular NAD was low. This is the Clearly test. So remember, it's a CT angiogram. We then take that disc, CD disc, send it to Clearly. Clearly then runs it through their AI program. But again, they're going to tell us not just what the plaque burden is, but how much of it is calcified and stable and really not that big of an issue unless it's space occupying, versus that plaque which is soft and could potentially rupture. And they are able, through their AI computers, to take the images and straighten the arteries out so that you can actually see some of the areas here where there's external plaque burden, seeing a little bit of narrowing in the artery there, a lot down here, but interestingly, no plaque in that one.
And any intermediate, do they look into intermediate layers as well or not?
Yes, they're looking at the entire vessel. Yes, the entire vessel. So you're looking at the endothelial layer as well as the muscularis and everything. And here again, you can see more plaque burden up at the top. But non-calcified plaque, that's that fluffy plaque that's at risk for rupture and potentially could cause a heart attack. And just one more there. All right, telomeres. So telomeres, I'm sure everybody knows, they're the protective end caps at the ends of our chromosomes. It's non-coding DNA. I always tell my patients, when your cells divide and you have to replicate your DNA, if we didn't have the telomeres there, we would have died out as a species a long time ago because our coding DNA would have been eroded. But when those telomeres get critically short, those cells can no longer divide. They no longer become functioning members of society. And so they either die, which is preferable because we can chomp them up and recycle the amino acids and things like that, or they turn into these zombie or senescent cells, which cause a lot of damage. I do use life length, and this is showing this particular gentleman. Yes. So this gentleman had been seeing another doctor for about 10 years before he became my patient. He had him on human growth hormone. I will prescribe human growth hormone. It's not very common, but what I tell them is if you're on human growth hormone and you're causing cell growth and division, you need to be looking at your telomeres, and you can see he's in the 1 percentile. So yes, he has some muscle mass, but at the expense of his telomeres. And so right now he is off his HGH, and we have him on an extensive telomere lengthening program. This is his shortest 20th percentile. He's slightly better at 19%, but he's still in pretty dire straits with that. So again, we look at these things, but we're not just like, oh, well, we're going to come in and say, what kind of therapies do we have? I've used TA65 for approximately 20 years. It worked on my telomeres back then. I was able to regain about 20 years worth of telomere length. Epitalon is a peptide. Again, yesterday I said the FDA just put that on a controlled substance list. Tells me Big Pharma wants it. Otherwise, why would they do that? Hyperbaric oxygen can help with telomere length. The new product from Quicksilver Scientific, Longevity Elite and Longevity Phytocaps, also have some of the astragalus in there that is helping with re-lengthening telomeres. Very interestingly, a lot of studies on meditation showing that it can lengthen telomeres. Stress management. Stress in and of itself, you can take someone, measure them, they have a very stressful life event, death of a parent, death of a child, something happened, divorce, and their telomeres will take a major hit. You can bring them back, but sometimes it's a matter of getting them out of their stressful environment to begin with. And then these placental-derived protein arrays, these are the cell factors that we are now using, and that's quite effective as well. That was a very fast and furious what I do in my practice. Thank you very much.